And to measure gross supination and pronation, which involves the talo-crural, midfoot, and forefoot, you apply the proximal arm along the tibial crest, the axis between the malleoli, and the moving arm between the second ray. You should have about twice as much inversion as eversion, and move to first resistance. This may be better referred to as inversion or eversion. This is a triplanar movement that involves several different joints. Now we're going to measure rear foot supination and pronation, not eversion, inversion, because there's equal parts frontal and transverse plane motion. We are getting a primary movement in the frontal plane, but we're facilitating transverse plane motion as well. She's a little stiff here into eversion, with only 5-6 degrees available. In inversion, or supination, we will invert and allow some transverse plane adduction to occur. And then measure. Ankle or talocrural dorsiflexion involves lots of different structures. To proceed, we're going to 0, or in this case 90, the inclinometer on the distal fibula, trying to make sure that you're off as much of the perineal soft tissue as you can. We need to consider that the plantar flexors, gastrocnemius, soleus, as well as the deep posterior compartment, posterior tib, FHL, FDL, and even the lateral compartment, PL and PB, peroneus longus and peroneus brevis, all could potentially restrict this motion. For the gastroc with the knee straight, we're going to make sure to place the round surface of the inclinometer directly on the calcaneal bone without pushing the ankle into plantar flexion or dorsiflexion. So compress without adding ankle motion, and make sure you're not slipping off the fat pad. The lines that you've drawn on the bisection of the leg and the calcaneus should help guide you to ensure that you're in the talocrural and sub-talar neutral. Apply a force to first resistance and measure. You can see here she's got about 5-6 degrees, minus 5 to 6 degrees, which is normal. We have her active assist. She takes that to about 12 degrees, which is functional. And then, once we flex the knee in order to slacken the gastrocnemius, we repeat the same procedures. Roughly 10+ degrees is normal. She has that available. And then with active assist, we should get another 10 degrees or so. So an isolated, non-weight bearing talocrural motion with an attempt at blocking subtalar joint and mid-tarsal joint compensations, she has 20 degrees available. Close kinetic chain measurement should be 40 to 50 degrees and should be compared and put in context with this measurement. And although not shown here, if you wanted to isolate or at least bias this stretch towards the plantar flexors, which you can see the peroneus longus and brevis tendons very easily in this image, you would want to invert the foot slightly and ensure that the patient feels a light pull along the lateral compartment. If you wanted to isolate this to the posterior tibialis, you would reverse the procedure and dorsiflex off the axis to facilitate pronation during dorsiflexion. And again, to attempt to find out where the patient feels it, to ensure that they do not feel it in the location of the gastrocnemius up near the posterior knee. And to test the length of the flexor hallucis longus, add slight pronation, maximum dorsiflexion of the first MTP joint, and then repeat this procedure. Any substantial reduction in motion through these procedures may indicate that those are the muscles that are the restrictor and not one of the superficial posterior compartment muscles. Reverse the procedure for talocrural plantar flexion. Grasp near the talar head and plantar flex. Remember, there is a slight inversion component. And measure. 40 degrees roughly is normal. If you would like to isolate this, if you would like to look at a gross measurement to include metatarsal joint compensations, use a goniometer and use the fifth ray instead of placing an inclinometer on the calcaneus. And ensure that you apply substantial force to the midfoot so that you can get a plantar flexion measurement that includes the talocrural joint and the midfoot. And to bias this towards the anterior tib, add a little bit of eversion during the plantar flexion. And to bias this towards the extensor hallucis longus or the extensor digitorum, flex the toes during this plantar flexion. And then determine where the patient feels the pull and try to discern which soft tissue is involved in the restriction. For the distal Tib-Fib, first found the malleolar axis. Most people have a bit of external tibial torsion, or at least are going to have some external rotation. So some internal rotation is typically going to need to be taken out of the leg. So make that axis parallel to the floor. And then we're going to zoom in here and we're going to do a pincer grip, and we're going to glide it posteriorly and anteriorly, finding the point of most movement. Alright, to mobilize it, it's important to get the tibia stabilized in the cup of your hand firmly against the treatment table. With the mobilizing hand, use your thenar or hypothenar eminence and apply pressure in the joint plane to the fibula. Vary how much tension is in the skin to make it more comfortable for the patient. If you didn't take out the torsion, you're going to make sure that you're angled somewhat lateral to medial. And for the mobilization with movement at the distal Tib-Fib, make sure you have the tibia stabilized. Take out a bit of the torsion. Have the patient move in their joint plane slightly up and out. Use your thigh if necessary. Apply a posterior glide to the fibula, stabilizing the tibia, and performing active assist range of motion of the talo-crural joint. For the superior Tib-Fib, it's important to stabilize the tibia and the femur, a bit of compression down into the table, and then find the joint plane. Find the path of most movement as you do a anterior to posterior direct mobilization. Maximum anterior, maximum posterior, to get a sense for the maximum possible excursion available. For more force, using digits 2 through 5 in your thenar eminence can be a bit more comfortable for the patient. Notice there's a lot of skin movement and tibial rotation, so you may want to consider the comfort for the patient there and how much is actually occurring at the tibiofemoral joint. And if you're not getting enough anterior glide in that position, prone works fairly well. Zoom in. You can clearly see the movement here. She actually is a little on the hypermobile side. Either hand position is okay. You just have to consider the comfort through the soft tissue and some of the peripheral nerves. With an AP glide of the talus and the talo-crural joint, it's important to respect the joint plane and to find the talus clearly. The sinus tarsi, find the soft spaces medially and laterally. Those are lateral borders of the talus. Then find the center of the talus. Respect that there's extensor hallucis longus tendons on top, so you want to work either around it or make sure that they're slackened. And remember that the movement is dorsiflexion AB, plantar flexion adduction. It's important that you're in the joint plane. In a healthy, mobile talocrural joint, the talus will completely disappear. If not, we'll move forward to mobilization. Now, when you mobilize the talocrural joint, oftentimes the knee is going to pop up. So if you want to isolate the movement and have a consistent axis of a glide and minimize the amount of rotation, you can stabilize the tibia with your hand or strap. Also, it may be easier if you take out any external tibial torsion. So internally rotate the limb until the axes are parallel. Refine the path of least movement. And apply a pure anterior to posterior force, using your leg as necessary to stabilize the forefoot. If this is uncomfortable, place a soft piece of foam or a towel underneath to prevent any discomfort that would arise from the compression of the soft tissue on the bones of the leg. Now, if you want to isolate some of this motion to the sub-talar joint, there is a small amount of posterior glide that can occur with the talus on the calcaneus. You can stabilize the calcaneus by compressing it into the table and apply a glide to the talus into a posterior direction. Typically, you're going to glide into slight inversion, which shown here, I might be in a bit too much eversion. This is going to be necessary for those people who have a chronically subluxed talus medially and plantarly. So therefore, you're going to want to get the talar head more lateral and posterior. You can follow this up with a mobilization with movement, having the patient pull up and out. If the extensor hallucis longus is in your way, in the anterior tib, you can use the web space of your hand. Considerable amount of force can be applied using this technique. And for the mobilization of movement into plantar flexion, one of the few techniques you'll need to restore plantar flexion, you're going to stabilize the lower leg, tibia, have them plantar flex and slightly invert, and apply a force to the talus to encourage the talus to move, therefore isolating the movement to the talo-crural joint. For an anterior glide of the talus or a relative posterior glide of the limb, you can use this position with the foot flat on the ground. This also serves as an anterior drawer, so we want to ensure there's an intact ATFL ligament and there is in fact restriction of the talo-crural plantar flexion before using this technique. For the talo-crural distraction manipulation, you want to be sure to take out the skin slack with your pinky and reinforce your hand over hand as you apply a force that is in the joint plane. So play with inversion and eversion and respect the tibial torsion. Find the angle of plantar flexion dorsiflexion where you feel some slight restriction. You want to make sure that you do not distract the hip, knee, and pelvis. You keep tension along the table, skin on leather. A premanipulative hold at end range, followed by a thrust.